Welcome, everyone, to another episode of the Community Health and Capital podcast with the 19 Hills Community Interest Company. I'm very excited to say we've got with us today Dr. Karen Sankey. Hi, Karen.
Hi, Johnny.
Karen is a fellow traveller in disruption, in passionately trying to work on health inequalities, and also comes from a community interest company position herself. So tell us, Karen, you've been working on this organisation and this model for some time. Tell us about it if you can.
Yeah, so I guess for the last 10 years, I've been a combination of sort of being frustrated with working within the framework of the traditional biomedical model and seeing how that doesn't work for many of the patients, particularly those with complex needs, and then also my passion to address social inequities and health inequalities. So it started about a decade ago, where I left my role as senior partner in a GP surgery, and basically I've been on this quite wonderful journey, really, quite up and down journey of trying to sort of really understand what it is people need. So that's taken me on, quite an interesting journey of training and learning, which then has culminated in the community wellness model and the community wellness company. So we set the company up 2021, and that was a result of basically a lot of time spent with marginalised and vulnerable people, actually just being with them, just listening to them and understanding what it is they actually need, what the barriers are to them accessing support. It's also been testing. We've tested out quite a lot of person-centred models of care. So we've actually been out in communities working with different cohorts, so working in homeless hostels, working with serious offenders, working in communities, deprivation. And actually what we do is we recruit members of the community, members of the people we're trying to help, to actually be part of our team. So we work together and actually design programmes that respond directly to the needs of people. So it's quite a different approach to the traditional sort of public sector offer, where somebody quite senior usually decides what a service needs to look like. And in my opinion, the sort of lived experience involvement is often quite tokenistic. So this is genuine collaboration with people. So we launched Community Wellness Company in 2021, and basically the combined learning and insights we've gained over the last decade has basically helped us create this a model. So it's a trauma-informed psychosocial model, which is community-based, so very much led by the community and delivered with the community. And it's incredible. It's literally transformational. It's the best work I've done in my 30-year career as a medic. Yeah.
And Karen, you know, you've obviously poured so much of yourself into this, and to do this at a time of 2021 where we don't need to spend too long talking about what was happening around that time, I guess, do we? But where was the motivation for this? When in your professional career did you decide this is just something that I need to do and I want to do?
Do you know, I think I really naively went into medicine because I wanted to help people. That was the fundamental reason, which sounds very sort of naive now, but I just increasingly felt, as a GP, you know, confined by that sort of traditional model, I just wasn't helping people. So I've always tended to work in areas of deprivation. I've almost been drawn to the people with most need. That sort of felt, I don't know, just felt like the right thing to do. And just increasingly, I was finding that I just wasn't able to help my patients either. I didn't have enough time with them. I didn't have the skills and I didn't know what to do with them. I couldn't access, you know, the support in secondary care. And I think that's become increasingly challenging over recent years. But actually, just this revolving door of people just coming back and thinking, oh, what do I do now? Do I try a different drug? Do I increase the dose? Do I try, you know, this sort of seeking for some magical cure all the time, and just feeling that we couldn't find it. And actually now I know it's not there, certainly in the NHS. You know, there isn't a magical drug or a magical therapy that's going to fix people that, particularly, let's say, many of the people I work with have complex mental health, or perhaps problems with dependence, or chronic pain, and just symptoms that are just chronic and recurring. And say that was probably the driver, I think, just that real frustration of not being able to help people. And I think it really hit 2016 was just such a low point where I was so disillusioned with medicine, and I thought, actually, I want to leave medicine, but financially wasn't in a position to step away, and thought, I have to do something different. I have to work with people differently. And so it was really sort of this search for being able to work with people in a more meaningful and impactful way. That sort of was the start of it, really.
And I know you and I have connected a few times, I think, over the last couple of years. And I think one of the memorable times, Karen, was when I think you joined a meeting with one of your colleagues who I think had come into the organization um, as a service user, I think initially. And it was so powerful just to kind of hear his testimony for, well, I can tell you how good this was, really.
Yeah.
Which must be very cheering because it can be quite lonely, I suppose, sometimes. But tell us more about what the model is and what it involves.
Yeah. So basically, we have a basic framework that we've created, which is a series of programs, which some are community-based, some are group work, and some are one-to-one work. And then we also run a volunteering and employment program as well, linking people. Again, my experience has been often people, particularly quite marginalized people, somebody will decide what job they should do. So we've had this experience quite a lot where somebody will be told, oh, there's a job in a factory for you. You think, but actually, does that person want to go and work in a factory? What are their skills? What are they passionate about? So for us, it's very much about working with people using a very strengths-based approach to understand what is it they're interested in, what would they like to do. So interesting, the chap that you met with me, I can't remember how long ago that was. He's just started in Wrexham University. He's training as a counsellor. So he works in our team and has gone full circle from being homeless and struggling with his mental health, being on lots of medication, in and out of alcohol and drug services. And he's now been sober for over 2 years, doesn't take any medication, started volunteering with us in 2022, and then became one of the paid members of our team as a community navigator. So he offers peer support. And what's really fascinating, Johnny, is he's actually as popular, if not more popular than me in our programs. So we have people coming in, he has no formal qualifications on his CV. And yet we have people coming in to speak to him because they found the interaction with him is more powerful than, often people say, more powerful than anything they've experienced in the NHS. These are often people that have been in and out of mental health services or drug and alcohol services. So I think, yeah, there's been a huge amount of learning in working with people that have experienced real trauma and real difficult times, and actually what they can then bring into programs to support others. And so we have this beautiful, diverse team of people, professionals, and so people with learned experience, but also people with lived experience. And we come together in a very non-hierarchical way where we really recognise, embrace everybody's expertise, not just very hierarchical that I'm no more important because I'm a doctor. I'm one of the team, that I bring something to the party, but equally other people bring their contribution, which is as valuable.
No, I'm the least important, right? We're the least important. I try to remind people that we invented medics and doctors at a time that all we could do is prescribe opium and hold people's hands, really. We regulated doctors, and then I think I'd like to think we've developed some kind of useful tricks along the way since then in the mid-19th century. But I'm sure there must be, well, there is, isn't there? There's always so much you learn from doing something different and doing something independently and doing something new and doing something interesting. But what would some of the things that you've learned since 2021 be in terms of the kind of service and support that you've been providing?
I guess the fundamental principles of our model is about basic human need. What do we all need as humans? So interestingly, this work started very much focused on the most marginalised. So it was very much working with people experiencing homelessness or complex mental health or addiction, prison leavers. And what we've actually discovered and how the model has evolved is it's now become a much more wider community model. So our most recent programme that we've just run for 6 months, that's just sadly had to finish due to lack of funding, so has basically, we've just seen an incredible diversity of people attending. So it's an open access program where anybody can come through the door, and we have those sort of quite those people that are always referred to as hard to reach, which makes me really cross because people are not hard to reach. We just don't know how to engage them. And actually in community wellness, we do know how to engage those people. So we get people who perhaps are banned from services or very marginalised, so they access our projects. But equally, we get people who, we've had a guy recently who was a burnt-out businessman, and he's been coming along, and people who are lonely. So we've had this incredible diversity of, our youngest participant has been 2, and our eldest is 84 with dementia. So it's been really about rebuilding communities and actually recognizing what humans actually need to be well. I think another frustration, one of the frustrations I have is this: we're very wedded to this medical model that sees people are broken and have chemical imbalances and medication is going to fix them. And actually for mental health and addiction, that's just not true. We don't have the evidence for that. And the growing body of science will say that, all of our mental ill health and addiction is a normal response to what's happened to us, particularly in our early years. It's a normal human stress response. And so we very much use that approach. We recognise that what people are experiencing is a normal response to their experiences. And then we create those safe spaces for people to come in and be together. And actually, when you look at the science, the one thing that actually makes us well is relationships. It's relationships. Most of our trauma happens within relationships, and actually our healing happens within relationships. And that is more powerful than any pill or any therapy. And that's been the biggest learning for me. Is I've trained in quite a few of the therapeutic modalities. So I work as a sort of a trauma trained therapeutic coach and mentor now, but actually it's the relationship is more powerful than the modality or certainly a medication. And I think the impact we're seeing will prove that, really. People that have been in and out of mental health services and addiction services for years are getting better. They're coming off medication. They're no longer using substances. It's quite incredible. Yeah.
And I think, I'm sure the professionals that have been seeing people who've experienced and suffered trauma, complex trauma, multiple trauma, aren't just GPs really, but I think GPs have over the years been those that are definitely seeing some of
Yes.
those people, really, aren't they? And I think probably, is it that some of those professionals have been too busy or not the right people to describe and promote some of the challenges? Because I think I remember reading, I forgot the book, talks about child trauma, the psychiatrist in the US. Catherine Thomas, who we both know, obviously, was the one who recommended to read it. And it is a heart-wrenching book to read, really, isn't it? Because kind of reading a chapter after chapter about kind of people that have experienced childhood trauma is not easy to read, really. But I thought it was very interesting when they spoke of there's been a lot of resistance to recognizing scientifically child trauma because it can uniquely it kind of some unique qualities or characteristics to it compared to lots of other kind of phenomena, I guess, really, in medicine. And I think it's great that in some ways we've recognized finally adverse child experiences is a thing and multiple adverse child experiences is a thing. It's great that I think more people are talking about trauma and talking about being trauma informed, but it's great also to hear that there's people like yourself, Karen, that can describing specifically what that is and specifically what it means to be doing that, really, because I think sometimes a lot of these things are still spoken about in abstractions. I don't know what you think.
Yeah, and I think it's really interesting for me. I've just finished 12 months training with Gabor Mate, and his work is really quite inspiring. And actually, his take on trauma is actually that it's not actually what happens to us, but it's sort of the physiological and psychological reactions in our bodies, and actually, it's much more widespread than we think. So, I think, while the ACEs work has been really helpful in raising awareness of trauma, I think also it's quite reductive in its approach. So I think many of the sort of my GP colleagues, I talk about trauma, they'll think about this small group of traumatized patients, when actually when you listen to what Gabor Mate talks about, he'll talk about traumatic stress happening to us when we don't get our needs met. So it's not just what happens to us, it's what doesn't happen to us. So when we don't get our needs met as children, often not because our parents don't love us, but because they actually don't realize what we need. So the emotional needs, I think this is increasingly a problem at the moment, which is why we're seeing so many young people with poor mental health, because parents are stressed and busy and children aren't getting the attention they need. They're not getting listened to and perhaps getting sort of accepted. There's a lot of pressure on what you achieve, and in the Western culture, you're successful if you achieve and if you accumulate material possessions. And actually, a basic human need is just to be accepted for who you are, just for being. And also, I think there's a lot around being able to express emotion safely. And again, in the Western culture, we don't tolerate that. So children who are having a stress response and having a tantrum get punished. Somebody that it gets angry, who's in probably a fight response, which is an automatic response, not a deliberate decision, will often get punished. And so we see our most traumatized people in prison. People with most need actually just get punished. And actually what those people need is connection. And that's very much what our work does. It's about connecting with people and not judging them. So we almost go back to basic, human need, childhood needs of, seeing and hearing people, validating their experiences, actively listening to them, giving them attention, and allowing people to express emotion and not feel that they're bad for feeling that emotion. And it's those basic fundamental needs make a huge difference.
And what response have you experienced in the public sector in general, I suppose, from this kind of very asset-based approach you've been taking, Karen?
I think, if I'm honest, my experience has been, it's been difficult. I think 10 years ago, I was very much ostracized and seen as the crazy GP. I was actually introduced as the mad GP in meetings. And I think what's frustrating is there's almost an ignorance about this, about this evidence base. We continue to spend millions of pounds a month on antidepressants with no solid evidence base that they actually cure anything. They numb your emotion, so you might feel better, but they're not a solution. So we continue to keep doing these things that don't work. The detox, chemical detoxes, which we have a less than 5% success rate, spending all this money. And I think my experience has been some people that make decisions, a lot of them aren't prepared to be open-minded and consider other approaches. So it's very much that they know best, and the work, like our work, gets dismissed as, oh, it's just another community project, oh, it's just fluffy stuff that you do. And that's certainly been an experience. I do think there's a growing recognition, and certainly between my colleagues, GP colleagues, have really come on board now. And I think they're witnessing firsthand, particularly the local GPs who have been referring patients into our programs. They're completely blown away. They're saying, how is this happening? How are these people getting better? These are some of our most complex patients that we've been supporting for years, and suddenly they're no longer drinking, they're stopping medication, they're volunteering, they're getting better. How are you doing this? And so there's a real appetite from peers in wanting to learn how to do this. Particularly around the trauma-informed coaching as an approach to working with people who are mentally unwell. I think there's also some recognition sort of nationally from, I'm a Bevan Fellow with the Bevan Commission. I think they're very keen in showcasing this work and looking at how it could be adopted as a way of working in Wales. But then it goes back to the sort of the fund holders, the middle management often, who I think, let's say, my experience, and there's some very good people working in the public sector, but my experience has been often they're not interested in getting curious about anything different than what they know. And that's a real barrier.
And it's tricky, isn't it? Because I suppose people in a position that has decisions over what direction services take and how services are delivered, I think if we can agree on one thing across the UK, it's that what we're doing right now isn't working. I suppose, really, whatever you want to call it, kind of broken, however you want to describe it, what we're doing right now isn't working. But it must be tricky to know, how do you sort what is a good direction taken? Because people, when they recognise things aren't working right now, all do come in with their unique slant, and we'll take it this way, take it that way. And it must be very challenging to sift between, projects such as yourselves to have a clear evidence base behind it and a clear vision, and not just a kind of vision as a kind of strap line or a vision as a kind of blank canvas, but a kind of, this is the detailed, specific vision that we think we can actually take this in as well. But it must be tricky to decide, particularly when I think the funding constrains what we do to an extent. And I think there are other nations across the UK that possibly are more comfortable around allowing not-for-profit, specifically not-for-profit entities to deliver services. I think across England there are definitely more of them there, but I know there has been some feedback around, they still face challenges because it's a new entity. People don't quite understand what it is. I think they're antibodies to the kind of limited company bit, really. And I think that's quite unfair and unfortunate, to be honest, really, because I think actually KICs are probably more scrutinized than some charities to an extent. And that's good because I think charities, when they're not scrutinized, do bad things too. But I think there's a big piece of learning I think we need to do around, this is just the third sector having more of an involvement in public service delivery, which isn't to say that the third sector should take on all public service delivery, because there's still a need for your standard default NHS services doing whatever it needs to for the average citizen or the average population. But if you were only to do that, we all know it creates gaps. There might be learning from those new entities, such as yours, of, well, actually, for your standard GP practice, it might be that we're not that inclusive. It might be that we're not that participatory. It might be that we kind of forget about a lot of people who don't manage to get through, that we could do definitely something more flexible for, that would allow their needs to be met equitably. But it's hard, isn't it?
I think it's hard. It's hard for third sector, and I think there's so much value in so much of what third sector organisations do. But I think we're seeing a similar pattern across general practice, aren't we? Across primary care, where the sort of lack of funding in primary care, the lack of recognition of the workload that primary care carries. And I think for me, that's probably one of the real observations, is that when I started out as a GP in the early 90s, general practice was a lovely job to do, but also I think we were actually in a position to be able to offer what our patients needed. So we actually, we had time with our patients. We knew our patients. We could give them that attention. So actually, we were actually meeting their needs. And in a way, the pressures now are that general practice has become this conveyor belt where you often don't see the same GP. You may just get a phone call, so you don't build up that relationship. So again, we've actually lost the relationships that we used to have, which were really therapeutic. So I do think that that's a real challenge in primary care. And I see that, I was a cluster lead for 5 or 6 years, and thinking that was possibly a way to drive some innovation. But I found a similar sort of resistance there, that we do pockets of really good innovation on the ground, because often those people on the ground know what's needed, but actually we couldn't then get it mainstream funded. And I think, it does take really brave decisions, I think, for commissioners to start decommissioning the things that don't work, where we don't have an evidence base, and actually to actually start moving some of the money more into prevention and sort of that upstream work.
Interesting. I was going to say before, Karen, that I would almost dryly own that mantra of you being introduced as the mad GP. You can make it your social media strapline or something, really, and joke about it forever after. But I'm sure we can put in, when we publish the podcast, kind of, how to get some more information, where to go to, and kind of what local people to you might be interested to kind of engage. But for argument's sake, for somebody on the other side of the country, if you were to talk back to yourself, who was in that kind of GP career previously, what advice would you give if people were interested in supporting your ambitions and supporting the work you do now, but in a mainstream GP practice service?
I think we've actually really overcomplicated things in the NHS, and I think it's about going back to basics. We recently won an Innovation in Health award, and it was quite interesting. We went to a fancy awards event in Cardiff, and there was all of these organisations who were developing new drugs and new technologies. And actually, we were a little community interest company that actually just, focus on human need. And I said, innovation doesn't have to be so complicated. We can go back to basics. We've lost sight of basics, of basic human needs, of building relationships, just strengthening communities. A lot of participants that come into our projects actually don't receive any therapies. We offer trauma therapies within our spaces, but actually many of them don't require that. They come along, and just being in that safe space and belonging, a sense of belonging, that sense of purpose. We let people help out, so people will come and volunteer with us on a very ad hoc way, people that perhaps aren't allowed to volunteer in traditional volunteering roles. And actually, you just see the change within a matter of a couple of weeks. People will be lighter, be smiling, will be, and it's really interesting. I've had a message this morning. Our program that we've been running for the last 6 months, which has supported about 160 people, sadly had to finish. And I had a message from one of the ladies that's been attending that said it was her lifeline. And she said, we're still meeting up, a group of us, every Thursday in the local cafe, waiting for when you can start the project again. But actually that sense of community, and it's really across the normal barriers that we see in society. So we might have, you know, somebody with addiction who's been homeless, who's really good friends with somebody that works but's off sick with stress, you know, and these really unique friendships that you don't normally see just get created. And then there's all this peer support where you know, everybody that we left in the program, we left them in a better place than we started, but actually they're now using the tools and resources to support each other in our absence. So, you know, I think a lot of what we're trying to do is move away from people being dependent on services to really empower people, that they have the knowledge and the tools to actually almost be active participants of their own health and well-being. We've even been doing some teaching people how to do therapy in pairs, so they do sort of a somatic therapy together. So just teaching people how they can just be, rather than being passive consumers of this service that doesn't really understand them, that they can actually just be, you know, active contributors and also valuable members of their community, you know, and that's so empowering for people.
Well, I have to say, for an entity that's only existed since 2021, you've definitely listed a huge number of accomplishments, I think, in that time, to be fair, really. But I also find it personally inspiring that it's obviously not enough for you, Karen, and you still want to do more and aim higher. How could anybody listening or watching this podcast find out more about your model and the organisation you've started?
So we have a website. I can share the link with you. I'm very happy to speak to people. I think moving forward, our problem has been trying to get financial stability and sustainability. So I think what we're thinking about is, obviously, if there's any funders out there, if there's people that want to donate, we currently have an urgent appeal trying to raise money to keep our programs running. So if anybody, particularly corporates who might have their corporate social responsibility, that would be fabulous. But equally, we're looking at, for me, there's something about how do I now share this learning that, you know, I'm heading rapidly towards 60 and thinking, you know, how do I share what I've learned over the last 10 years? And so we've started offering workshops, so in stress and trauma, and sort of consultancy around developing patient-centered or person-centered care and community models. And then we've also got a trauma-informed coaching training that goes live next spring. So I've had lots of people asking me, particularly GPs, how do you do what you do in 10 minutes in a 10-minute consultation? What can I do differently? So there's a whole piece there about the learning and what training we can develop moving forward.
I think that's something the NHS absolutely should be commissioning, and it's not just NHS, it should probably be all public services, to be honest, really. And I think you know, as we touched on, you know, moving away from the abstraction to specific kind of approach, really. I think there's a lot that could be taught to people that I think yeah, we need to get into action, don't we? So thank you so much, Karen. This is definitely one I'm going to listen back to, and we look forward to having you back on the podcast, you know, in a few months or years' time to kind of feel when we got to. This was another episode of the Community Health and Capital podcasts. If you've got any feedback on this episode, please get in touch at info@19hills.org. If you have got an idea for a podcast, or you're looking to come and be co-interviewed or be interviewed, we'd love to hear from you. Thank you, Karen, for joining today. Really grateful. And we'll look forward to publishing another episode very soon.